There aren't any other specialties in medicine that just use test as easy and cheap as the creatinine and pretend that represents all the important organ function.
Welcome to Convergence, an historical assessment of kidney diseases, nephrology, and health policy in the United States. I'm your host, Todd Ibrahim, Chief Executive Officer and Executive Vice President of ASN.
The story I would tell about the origin of the estimated GFR goes back to the days of the MDRD study.
That's Dr. Andrew Levey, a nephrologist who transformed kidney care, research, education, and public health during his career, particularly when he helped lead the modification of diet and renal disease, or MDRD study.
The MDRD study was the modification of diet and renal disease study, and it got started in the early 80s, and there was actually a congressional mandate that NIH study the effect of diet on kidney disease.
Why did Congress want the NIH to study this?
I think, Todd, this was an earmark. This was something that there had been studies by Bill Mitch and Mackenzie Walser showing that if you put people on a very low protein diet, you could slow the progression of kidney disease. So this was seen as something that was really important to study.
And why was it important from your perspective within the context of understanding the effect of nutrition on kidney disease or on kidney health? Why did you want to have this other sort of assessment of kidney function? I'm just trying to figure out how you got to the point you got to.
Well, perfect question. Bill Mitch and Mackenzie Walser, who had popularized this notion of low protein diets in the US, it was popular in Europe already, pointed out through a series of studies of their own and quoting studies done previously by others that creatinine comes into the body in the diet. And if you reduce the amount of meat that you eat, you reduce the amount of creatinine in the body and you lower the serum creatinine, and it makes it look like the kidney function is better. Creatinine is also made by muscle. So if you lose body weight and lose muscle as a result of a change in your diet, or if you gain muscle, you change the creatinine. So we appreciated that just using creatinine could confound the results of the study. We might do a study that showed that if you reduce the meat intake, the creatinine goes down. It looks like the kidney functions better, but the GFR is not better at all. So between the understanding that diet could affect the creatinine and that creatinine clearance could be misleading, the MDRD study investigators said, we'll measure the GFR, we'll adapt one of these easier methods to measure it, so we're not using Homer Smith's method. We had guidance from the Cleveland Clinic, where they had been measuring GFR for years, as well as the Mayo Clinic using iothalamate, which is just a different molecule that you inject. And we set about to measure the GFR. So it turns out the MDRD study was, the results were equivocal. The results were inconclusive. The small changes in the diet actually had a discernible effect on the measured GFR in humans. We hadn't known that was going to happen. And the GFR went down faster in the low protein diet group, and then the rate of decline slowed, and we stopped the study right where the curves crossed. And so the study was inconclusive. And to this day, it's not really conclusive how much a low protein diet can slow the progression of kidney disease. But it is conclusive that it can cause effects on creatinine clearance, as well as the measured GFR. We published a lot of papers from the MDRD study, and Tom Green, the MDRD study statistician, said, I think we have enough data to put together a prediction equation to estimate the GFR from the serum creatinine and other variables based on the fact that we have thousands of measurements of GFR in the study, and we have these highly controlled creatinine measurements. And we might be able to do clinicians some good to put forward an estimating equation based on statistical techniques of prediction modeling. And so we said, that would be a good idea, Tom. Why don't you go ahead and see if you can do that? And Tom figured out a simple model, ultimately, using age, sex, and race, as well as the measured serum creatinine to predict the measured GFR. And it was a pretty good model. It wasn't perfect. There was a lot of variability. And we published that in the Annals of Internal Medicine in 1999 as a better prediction model than models that had been developed previously to estimate the creatinine clearance. That model was the Cockcroft-Gault model, and the MDRD study equation seemed to be a definite improvement over that.
Can you give me a sense as to how much of an improvement it was? Like, I'm just trying to, if you're in 1999, just how much of an advancement was this? Is there a way to define that?
I don't have the numbers on top of my head, but the estimated creatinine clearance by Cockcroft and Gault was always higher than the measured GFR and higher than the estimated GFR. So that's a measurement that we call bias. And that means that you are systematically off using the Cockcroft and Gault equation. And what you want for a prediction model is for the bias, the average deviation to be zero. And then you're left with scatter about the relationship, which is called imprecision. Even correcting for the bias of the Cockcroft-Gault equation, the precision was much worse than with the MDRD study equation. And I would say, using the metrics that we have, there's an error in the MDRD study equation, and the error in the Cockcroft-Gault, the precision, is maybe 50% more.
Okay.
And the equation that we came up with was not harder to implement computationally, although you could memorize the Cockcroft-Gault equation and do it on the back of an envelope, which you can't do for the MDRD study equation. So we had a better equation, and not much came of that just because we had a better equation. The big advance really was when the National Kidney Foundation formed the Kidney Disease Outcome Quality Initiative and wanted to put out a guideline about chronic kidney disease. They had been doing work for Dialysis Outcome Quality Initiative, the so-called DOQI, and they realized that a number of the problems that they were dealing with in dialysis started before the stage of kidney failure. They started during an earlier stage of what we now call chronic kidney disease. And they put together a guideline panel, and I was fortunate enough to be able to lead it, where we put forward a definition and a classification of chronic kidney disease. And this was published in 2002. And so the kidney disease was defined and staged according to GFR. It was not stated whether it was measured or estimated GFR, because we knew that there were multiple ways to measure GFR, multiple ways to estimate it, and that we wanted clinicians to use the best method available to them. And then they could use that to detect kidney disease, stage it, classify it, create guidelines as to what to do when you found it, slow the progression, treat complications, and they all became GFR based. And I think that's where the explosion of interest occurred with estimating GFR. The guideline group recommended that clinical chemistry laboratories should report estimated GFR whenever serum creatinine was measured. The American Association of Clinical Chemistry and other clinical laboratory groups took up the challenge. The NIH formed the National Kidney Disease Education Program, and Tom Hostetter was head of the education program. And as part of that, he put together a group to standardize the measurement of creatinine in clinical laboratories across the USA. And because laboratory instrument manufacturers are international, this really led to the standardization of creatinine measurements across the world. Laboratories began to report the estimated GFR. Clinicians started to think in terms of the estimated GFR, and there were thousands of papers produced.
Initially, we thought we wanted to do this history. And as I talked to Andy yesterday, I was really struck that the original sort of activities related, the MDRD really related to nutrition and kidney function. And then it sounds like they kind of backed into the eGFR equation.
I think that's right.
And I'm just curious as to, at the time, what your reaction to that was.
I was at the NIH, and so we had to get the lab companies to buy into it. And I remember one of them told me how many dollars it would cost at some meeting at the NIH.
Former ASM president Dr. Thomas Hostetter is a nephrology titan whose 50-year career has spanned academic leadership and public service, including a role at the National Institutes of Health.
To add the extra printing. And he turned out to be a good guy. His name was Harvey Kaufman. And so we had to get them to buy into it. And so we had a meeting at the NIH with these folks, and Harvey came up with how much it would cost them to print that extra set of lines. And then we had another meeting out in Los Angeles at some pathologist meeting where I went. They were more receptive then, and they agreed to what was then a certification of the validity of the measurement of creatinine, which would come into the lab companies would have to do that. And it was the National Institutes of Standards and Technology, which turns out to be a part of the Commerce Department. And they were very helpful in doing HPLC measurements of creatinine. And that was the way, and I think almost all of the lab companies have bought into that. And they buy standards that are certified to be in accord with the NIST. That's the short name for the National Institutes of Standards and Technology. I guess it still exists. Many of these things don't anymore, but that's the way it happened.
After talking with Dr. Hostetter, I had more questions for Dr. Levey. One question that I have is, because the eGFR is estimating the function of the kidney within a broad context, there are some issues around the aging kidney, and that perhaps there's a sort of overestimation of the number of people who could have stage 3 kidney disease, for instance. And I'm just curious as to how, at the time, you thought about that issue.
The issue you raised about the effect of aging on kidney function and kidney disease has been an interesting question for before we got into estimating the GFR. It's really a question about the GFR itself. It's been known for a long time that with aging, the number of nephrons goes down, the number of glomeruli goes down, the filtration rate goes down. And therefore, any definition of kidney disease that's based on the GFR, not the estimated GFR per se, but the GFR, will have more people at older age, right, who meet the criteria for kidney disease. This is actually very similar to the issue of blood pressure. Blood pressure goes up with age. If we have a definition of high blood pressure that's based on a single number, there'll be more old people than young people with high blood pressure. It's true for cholesterol, it's true for elevated glucose. So when the guideline group first met, we considered whether we ought to have different thresholds for reduced GFR based on age. And we just thought it would be too complicated. Right? You can imagine that if you had a reduced, if you changed the threshold, made the threshold lower to qualify for kidney disease with age, that you'd have some people on their birthday who had kidney disease before who no longer had it the next year. even though there was no change in clinical status. You might have to consider changing the staging based on age. And so we picked a number of 60 to define kidney disease that reflects about the loss of half of GFR from the young, healthy adult status. And since we don't know what the cause of the lower GFR in older people is, right, we were just agnostic about it. We said the most important thing would be the prognosis. Is the low GFR in older people bad for you or bad for them? And we were able to conduct a lot of studies that showed definitely, both in the young and in the old, having a lower GFR was worse for you. Now, the risk relationships in the old are different than in the young, but the same is true for diabetes and cigarette smoking and high cholesterol. It turns out that the risk of bad things happening when you're old is higher. So the relative risk due to any one risk factor is less strong. And we see that in kidney disease, but we see that in virtually every other disease as well. So for simplicity, to avoid the birthday phenomenon, because we don't really know the cause of decreased GFR with aging, but most important, because it's a risk factor, no matter the age. The guideline groups have, for more than 25 years, have opted to keep the definition the same. And I think it's been worthwhile to have the same definition over all this time, because you haven't had to see guidelines change just based on the changing in definition. Now, the eGFR behaves the same way with age as the measured GFR. Although with creatinine, because muscle mass goes down with age, creatinine is a worse marker for kidney function at older age than in younger people. Cystatin, if anything, seems to be almost the opposite. Things look a little worse in older people than they are. So between creatinine and cystatin, things average out pretty well. So that's where we are for the current status with those two markers. I think we're doing a lot better than we were before we had a way to estimate the GFR. We had clinicians talking about different creatinines, knowing that they were different in men and women, knowing they were different in young and old, and knowing that they were different in black and white.
Yeah, to that last point, this has been the other big controversy, and I'm just curious as to, as the group was coming forward with the recommendations, and you'd mentioned that you had adjusters for age and for sex and then also for race, and just if you could just explain that history so that we all understand it.
Sure. We saw in the MDRD study that the relatively small number of African Americans that we had, I think it was around 10%, that for the same level of creatinine, they had a higher GFR. We also saw that older people for the same level of creatinine had a lower GFR, and women for the same level of creatinine had a lower GFR. So these were what we call significant variables that affected the creatinine other than the GFR. And we were just trying to make the most accurate equation that we could. And we thought that would be better for patient care, because that avoided non-GFR influences on the estimated GFR. And actually, we thought that was a big improvement in our equation over the Cockcroft-Gault equation, of the MDRD study equation, over the Cockcroft-Gault equation. And we had solid epidemiologic data to know that this was not just a feature of the MDRD study. Camille Jones and her colleagues had showed this in NHANES. So we didn't know exactly what the cause was, but since creatinine is made by muscle and the creatinine in the diet comes in from eating meat, we hypothesized that African Americans in the MDRD study had a higher muscle mass than the non-African Americans, and that this might be a muscle effect. on creatinine. We did not really anticipate that specifying age, sex, or race could in any way be a handicap to patients getting good medical care. But indeed, when people began to get concerned that at the low end of kidney function, that people on the waiting list were not getting put on the waiting list inappropriately, this became something that people didn't want. I mean, not all people, but people didn't want to have their race included as part of a kidney function estimate. I think the GFR equations that we put out, both the MDRD study equation and the CKD-EPI equation that the NIH funded some years later, was that the errors among African Americans were not greater than the errors in non-African Americans. If you use a prediction equation and you estimate the GFR and it's wrong, that person can be harmed. Since we didn't understand the biological basis of the association of race with creatinine, and because it didn't seem likely that it was an innate characteristic of being African American, it seems now to me that it's much more likely that the African Americans in our study had higher muscle mass than the whites because of structural racism, segregation, limitation to jobs that people could get that involved manual labor, for example, where they had to be more fit and more muscular. But that's a more likely explanation. And because those aren't really inherent to the population in any way, it makes a lot of sense for me not to have the race variable in the equation. The new equations aren't quite as accurate as the old equations, and therefore there's still an issue as to, are some people being harmed by having their GFR misestimated? As a kidney doctor, I always thought that you could do another test. You could measure a cystatin, you could measure a creatinine clearance, you could measure the GFR in order to make the right decision for your patient. But it turns out the estimated GFR is just used all the time, and all of those other measurements are harder. So I think the new equations are good enough and don't require specification of race, which is objectionable.
As we move more toward algorithms in medicine and more toward augmented or artificial intelligence, the point you've made several times about trusting the expert, in this case the nephrologist, to consider all of the inputs of information and make the right decision. I don't know how we balance that in the new world, if that makes sense. You're raising something, there's a real sort of humanity here that I think is going to be lost.
Oh my goodness. Our prediction models will get more complicated. They'll get more accurate. How well people will appreciate the limitations in the models will be hard to see. I think that with more accurate predictions and better algorithms, we'll probably deliver better medical care. I think the experts will always understand stuff better than the non-experts, but it's the non-experts who are going to be delivering most of the medical care in the future as it is now. Before nephrology gets there, I'm interested in nephrology just getting where other specialties are. There aren't any other specialties in medicine that just use tests as easy and cheap as the creatinine and pretend that that represents all the important organ function. So going beyond that panel of filtration markers or to measuring the filtration rate to get other markers of kidney damage and other markers of kidney function seems to me a place that we want to head. All of those other tests are more expensive than the creatinine, but there's no test that's less expensive than the creatinine. So using the idea that we want to stay away from more expensive tests can't be the only answer. But I think doctors in the future and nephrologists in the future are going to need to know a whole lot more than we did.
So Crystal, when did you first become interested in the concept of estimating kidney function?
Yeah, that's a great question. Actually, I feel like I was born into the age of estimating GFR.
A member of the NKF ASN Task Force on Reassessing the Inclusion of Race in Kidney Diseases, Dr. Crystal Gadegbeku will serve as ASN president in 2027.
Because my first clinical trial as an early investigator was the African American study of kidney disease and hypertension. The measured GFR was a big part of that study. It was the largest study, I think, arguably to this day, it's the largest study in African people, Black individuals, African Americans, that was focused on kidney disease and hypertension. And at that time, we had evolved with the MDRD study and the estimating equation there. And one of the critiques or questions with the ASKS study was, could we validate the MDRD equation in a larger population? The MDRD study had 12% of Black individuals, and this was going to be a much larger study, 1,094 individuals to look at GFR. And Tom Green, who led the development of the MDRD study, was involved in the development of an equation in the ASK study. And then we did actually validate the MDRD equation. It was accurate as an MDRD. And I feel I grew up in the era of establishing estimated GFR and using that for evaluation of kidney function with the race modifier at the time.
So you mentioned both Black and African American people. And can you just help me understand how you think about both those terms, both how you thought about it in the past and how you think about it now? Because it seems like that's an important part of this story.
Yes, and even more so, self-reported Black individuals. And that's something that we use scientifically, self-reported Blacks. And when we think about the criteria in studies, we tend to use both terms. Black individuals and African American individuals. African American, too, was a term that kind of was developing to be more popularly used over the 90s, referring to people of West African descent living in America. But when we do these studies, we had included people who are Afro-Caribbeans, who are Afro-Europeans, who are from Africa. And so I have always thought that the use of Black individuals really was referring to people of African ancestry from various places, where African Americans was more specifically referring to people living and growing in America who were of African descent. And it's interesting because my father is West African and my mother was born in Washington, D.C. So I used to joke about how that I felt I was the true African American from two people, one African and one American. But that was my joke.
Yeah, and I guess the other piece of this, I'm smiling because I have a similar situation in the sense that my father was Egyptian and then my mother is most American. So does that make me African American? Or as I've always heard it explained, we really have to think about sub-Saharan Africa differently as we think about genetics. So I just wanted to clarify that point as well.
Yeah, exactly. Sub-Saharan African, West African, African American, confusing definitions that people have different perspectives on. I think the one thing that was really clear that came out in our deliberations with the estimating equations and thinking through them is how we are a multi-ethnic society. We are increasingly multi-ethnic, and it's really hard to think in terms, it's much more complex than thinking in terms of Black and white, literally, or Black and non-Black.
Yeah, so that's a nice transition to my next question, which is why did you agree to serve on the NKF ASN task force, which was charged with analyzing this issue and coming forward with recommendations?
I had done this work with Measure GFR, and I'd seen the development, the use of the MDRD equation, not only in the ASK study, but I was involved in the chronic renal insufficiency cohort. So I was supervising GFRs in both of those studies, supervised many, many GFRs. I feel that I had a really good understanding of how the measured GFR was performed and the importance of having an estimating equation that could be used clinically that was much less cumbersome than what we would do to get a measured GFR. So that was really important to me. Also, personally, as a person of African descent, a Black individual, African American, all of those things, I felt it was important to understand and to be sensitive to this issue. And we had very polarizing views of this. And myself, even, I have evolved in my thinking as when I started the task force, I came with this experience of creating, basically being there in the room when the equation is developed for accuracy and thinking through and broadening my thoughts to how we think today and where we are today with thinking about race and structural racism and the issues around having a race modifier. So I really felt close to the conversation, the discussion, and really wanted to be there to contribute and provide perspectives.
And so, what did the task force recommend?
Yes, so the task force was a significant, comprehensive deliberation of GFR reporting. It took 10 months. We looked at every equation, 26 equations. We also we had many experts, 97 experts from all across the world and in the US and as well as all across the world. We took into consideration healthcare professionals' views, trainees' views, patient views. We looked at implementation, population, public policy, population health, clinical trials. So it was an opportunity to take, and all the evidence out there pointing towards or against using a race modifier. So it was a very comprehensive look and a way to step back and think about the issue of having a race modifier or what equation would be best. And what we came out with in that time period, there was the refit equation that did not have race in it that was generated. We looked at the cystatin C equations that never had race. And we came to the understanding, as I said before, in a multi-ethnic world, in a time when race is often assumed in the clinical setting, that race should not be included in the equation. And so we came to use the refit equation, which did not have race in it. And we also appreciated the fact that that cystatin C, especially the cystatin C creatinine combined equation, was more accurate, and and we could do that without a race modifier, and wanted to basically support the use and recommend the use of that based on all of which we looked at and studied.
Yeah, and I should say you're underplaying it a little bit in terms of the amount of work the task force put in. So, not only did the task force meet weekly for 2 hours each week for 10 months, but then the co-chairs, Cynthia Delgado and Neil Poe, met with the leadership, ASN and NKF weekly. So there was a lot of evaluation, consideration, as you mentioned, a lot of witness testimony, a lot of open forums with the public. I feel like this was a very both transparent but also exhaustive process, and one that I think of proudly, especially because it started at the end of the COVID-19 pandemic. It was all done by video conference, which is pretty amazing when I think about it.
Yeah, I agree. It was quite a process. And I am too very proud of the deliberation we went through. And I thought we came across a decision that was highly thought out and very representative of all the groups that are important to the question. From that point on, to use the opportunity or leverage the information I learned from the task force to disseminate that information in presentations across the country, because I thought what we had done was so important to deliver and to let others understand how we came to the decision. And like you said, it's hard to really understand the amount of work that went into that when you read the article. So it was really nice to be able to add to that work by presentations and discussions and talking to medical students and residents and fellows across the country.
Yeah, I guess I have two connected questions. Where do we stand now in terms of estimating kidney function? And ideally, what will the future look like?
Yes. So I believe one of the things that came out of the task force is the real, honestly, the lack of accuracy of the biomarker we have, serum creatinine, in estimating GFR. That there are so many non-GFR determinants issues. Muscle mass was the one that was brought up in the beginning, but as we learned, there are many other issues, and we don't really understand the differences in creatinine relationship to GFR fully. And cystatin C is better, but not as available. And then we know that as we combine other biomarkers of renal function, we get closer and closer in accuracy. So to me, we had put to bed doing measured GFRs and trying to get accurate equations for screening and management of kidney disease. To me, it brought up the fact that we have more work to do with this, and we really should be thinking about the getting more accurate measures of GFR that can be clinically used. So that to me is really important.
So, just as we're closing, if you could give the audience a kind of sense as to what you think the next couple of years are going to look like in this arena, ideally.
Ideally, it would be wonderful to continue to think about the best way to measure kidney function. There's a couple of really salient points about estimating GFR. I think that nephrologists appreciate, but many physicians and healthcare professionals not in the weeds on thinking about GFR every day do not realize, and in particularly our patients. And that is that it is not as accurate as we like to be. When we get the GFR measurement, it's plus or minus 30%. Yet, because the estimated if equation comes out with a number 47, 89, it conveys a sense of exactness. And with that, we utilize this to we have created thresholds where we give certain doses of medications, for instance, chemotherapy, antibiotics. We decide on who is evaluated for transplant. And if we appreciate the limitations of the GFR equations, which are based on serum creatinine, we wouldn't have those. I think it is really important that we start to think about creating policies and using medications, appreciating the limitations of this study, or we go to the future of direct measurements of filtration, like the transdermal GFR measurements or other ways of measuring GFR that can be used clinically. So I see that as the future.
Great. Thank you. So, Crystal, you mentioned that the task force deliberated for a long time. Why didn't it just simply remove race from the get-go?
I had significant problems with that, because what that meant is of the 26 studies that had formulated this equation, there were about 3,000 self-identified Blacks. And if you were to do that, you were going to remove their data from developing the equation. And to me, that's the opposite of generalizability. And so I had a real issue with that and felt that we needed to come to another solution that didn't have the race equation, but that the solution of just not using it was not the best idea.
So one of the things that struck me during the task force's deliberations was this issue of self-reported. So how I define myself and my history versus how I'm reported if the physician or the nurse or another health professional describes me. I'm just wondering, as you think about that issue, what your perspective would be.
For me personally, as we were deliberating on this, I thought of my own family. So, as I said, I grew up a daughter of an African father, African American and Black mother, and my husband is Irish American, Welsh. And I started thinking about my kids and what they would call themselves. I think they would say they're multi-ethnic. And then if you have two equations, Black and non-Black, where would they go? And and further, if they went to a physician who wanted to estimate their kidney function, what would they assume? And so here were the real problems that I saw we were facing and why we needed to move forward with the recommendations we had.
Thank you for listening to this podcast by the American Society of Nephrology. I'm Todd Ibrahim, Chief Executive Officer and Executive Vice President of ASN. This podcast should not be used in any medical emergency or for the diagnosis or treatment of any medical condition. If you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment, please consult your doctor or another qualified healthcare professional. Views expressed on this podcast are those of the speakers and not necessarily those of the American Society of Nephrology. This podcast should not be used in any medical emergency or for the diagnosis or treatment of any medical condition. If you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment, please consult your doctor or another qualified healthcare professional.